So we're now 5 months later with this patient who had received 2 cycles of R-CHOP and achieved a partial remission, and this patient now presents with abdominal fullness consistent with, again, progressive disease. You do a physical exam on the patient now has marked splenomegaly and thrombocytopenia. PET-CT scan shows progressive disease, and at this point the patient actually gets a repeat biopsy and now comes back as a grade 3 follicular lymphoma. What we don't know is whether this is a grade 3A or a grade 3B, which is really quite an important distinction. Grade 3B really is a diffuse large B-cell lymphoma. In the current WHO classification, we would treat this as an aggressive lymphoma, and if that were the case, we would probably, if the patient was fit, give platinum-based chemotherapy, try to get the patient into a remission, and then consolidate with high-dose therapy and autotransplant. It certainly would be still a reasonable option, even in a 3A, or even if this was a grade 1-2 follicular. Autotransplant is something we can consider in chemosensitive relapse. So we don't really know the situation here, whether this is a grade 3A or a 3B follicular lymphoma. Another notable point is that this patient developed considerable anemia and thrombocytopenia. If you do a marrow and you see it's packed with lymphoma, then you have an obvious explanation. However, the patient didn't tolerate the chemotherapy very well in the past. The patient also had CMV infection. Again, that's sort of on my mind, about quite unusual at baseline, and you wonder if there's some underlying marrow disorder with this patient and poor tolerance to chemotherapy. This patient was started on idelalisib therapy, and after about 2 months on therapy developed grade 3 colitis, which was managed, and it sounds like the patient was restarted on therapy based on the case. And the patient had stable disease and is remaining on drug at the end of this case. The question comes up often is, well, what are the other choices besides idelalisib in this situation? I want to point out that there is a drug, a historical agent that we can consider, maybe not for this patient because they have 90% marrow involvement, but there's a drug called ibrituximab texacan, which is an yttrium-90 labeled monoclonal antibody. Commercial name is Zevalin. In those that have less than 25% marrow involvement, we would expect about an 80% response rate. So that's actually a really active drug, but you have to use it when the counts are decent and the marrow is not involved. So you can't wait too long to use that drug, but in appropriate patients, that can be quite an effective drug. There's another PI3 kinase inhibitor called copanlisib, which has recently been approved. Same label, 2 priors. This is an IV PI3K inhibitor, which is given 3 out of 4 weeks IV. So has a very comparable response rate, somewhat slightly different side effect profile, a little bit of hyperglycemia and hypertension following the infusion, and obviously getting an intravenous drug has a different time commitment than an oral agent.